Okay. So, good evening, everyone. By the time you finish your tea, you will have an idea about uh, things which is called what came first, sarcopenia or osteoarthritis or sarcopenia. It is just like what came first, hen or the egg. So, I will be sharing my video. Okay, so screen is there, and we are starting. So sarcopenia and osteoarthritis, it is like a vicious cycle. Rather than going into the controversy, what came first, egg or the hen, it is better to manage it and treat it. When I'm saying manage it and treat it, for that you have to understand what led to what, whether sarcopenia led to osteoarthritis or at some point of time osteoarthritis leads to sarcopenia, because it is a vicious cycle. And according to this understanding, whether sarcopenia is leading to osteoarthritis or the vice versa, our treatment plan will depend. So whether the muscle changes precedes OA or the vice versa, it is the disuse of an affected joint due to pain of movement may be the primary cause of the reduction in the muscle strength. It is primary, but it can be the secondary cause which leads to the pain, which we will see later. And also, most of the patients with osteoarthritis have this tendency to avoid the physical activity, which this avoidance of physical activity may be beneficial in a later stage, which we have to restrict during the rehabilitation of osteoarthritis. But at some point, physical activity is necessary for understanding the OA knee. When to go for the exercises, when to what exercises to be done, what interventions to be maintained, when analgesics or medicine is needed, and what amount is needed. And also remember, whenever there is muscular change, there is always a neuromotor system that is involved, and which depends on the force that applies on the ground reaction force that applies on the joint. Most common joint that is affected or that we are seeing in day-to-day OPD practice, it is the osteoarthritis of the knee and the hip. Although OA can involve any other joint as well. So the issue is if there is a muscle weakness, it will lead to exacerbation of the joint pain. And due to joint pain, there is always a possibility of joint dysfunction. And if there is a joint dysfunction, there will be a muscle weakness. And again, if there is a muscle weakness, again the cycle keeps going on. So when to do this intervention, and it is just like a vicious cycle, which has to be managed. So whenever suppose a knee is involved or a hip is involved, knee is the most common thing that we see, and most of the discussion I will be talking about the knee. So gait deviation will be there because of the muscle weakness. If there is a muscle weakness, there will be misalignment of the axis, and there will be change in the altered movement patterns, because joint reaction force vectors will be there that will be creating a region of concentrated stress along the sides, where underloading within the same joint there will be underloading, and the other side it will be overloading. Most common muscle that is involved in the knee OA is the vastus medialis. So accordingly, this misalignment will be there. If you see a patient with the OA knee with some deformity, it will be mainly the bowing of the joint, and that is the cause because of the joint reaction force vector, axial misalignment, and ultimately the muscle weakness. This is the most commonly the initially with VMO, and then the quadriceps weakness will be there. So accordingly, we have to plan that exercise or which muscles to work on and which muscle to avoid. And there will be always a stress heterogeneity which promotes the compartment specific degeneration. Always remember, if you see an osteoarthritis knee, the side which is most commonly involved is the medial side rather than lateral. If there is a lateral side more involved, then there is need to think about the other differentials as well. So there will be always a loading and unloading effect, because it always contributes to joint deterioration, which is driven by the pain avoidance or reduced physical activity. Now, loading and unloading is important because of the lifestyle. As you know, that one of the most common contributor for osteoarthritis is the lifestyle. All those who are wearing the high heel shoes, or not improper footwear, not the flat shoes, or the shoes which is more compact, more designable and fashionable. Those leads to loading and unloading effect, or the imbalance will be there, and that leads to the pain in the knee in the long run. So why physiological cycling is needed? Why loading is needed? Because with the loading, there will be increased synovial fluid circulation, and there will be nutrient exchange in the avascular cartilage. Cartilage is always avascular. So if there is some cyclic loading happening, that will lead to it, and chondrocyte metabolic activity will be. So this is the benefit of the loading effect of the joint, and prolonged unloading. Suppose we are leading a sedentary lifestyle, most of us are bound to the office work. We are not at all moving our joints. That or those because of other reasons. Someone is bed bound, or someone is not able to mobilize himself because of the itself the osteoarthritis. That leads to our progressive stage or the later stage of the osteoarthritis. Then that unloading, prolonged unloading leads to matrix dehydration, proteoglycan depletion, and loss of the mechanical stiffness. If mechanical stiffness is gone, then there will be more of a problem, more joint pain will be there, and that's why unloading prolonged should be avoided, and cyclic loading is necessary. And this cyclic loading and unloading formula is needed when we are training for the exercise. See, OA knee is just like a organ failure of a synovial joint. So whenever like a heart failure we have a liver failure. Similarly, the synovial joint, if you consider it as an organ, and there will be a failure of that organ, because the moment there is a failure, it will have some consequences on the muscle mass. There will be progressive loss of periarticular muscle mass and function, which lead to, if there is a loss of muscle mass, the first thing that will be affected is the joint stability and the health of the joint. And because of the strength, it will be attributed to myofiber atrophy. If there is atrophy, there will be reduction of muscle quality, and defective muscle regeneration will be there. And there will be increased cross-sectional area of vastus medialis, which improve the structural changes at the knee. Structural changes, if you want to improve, vastus medialis has to be worked on. And if the moment cross-sectional area of vastus medialis is increased, there will be reduced pain in the ONE. That's why exercise or therapy, whatever is being advised, it should be clinically monitored, not some YouTube or Facebook exercises that are available should be advised. So whenever you are examining a patient with OA knee, look into the condition of the vastus medialis. Try to palpate it. If the moment you palpate there will be some tender in it, and especially in the late stage of the OA knee. And there will be pathogenic fibrosis of the muscle is always has been seen in the patients with osteoarthritis. So muscle fiber shift has also been observed in the patients with osteoarthritis group, which is gradual. Initially, it is more of a 2A or a hybrid fibers, and fewer type of 1 fibers in OA muscles has been seen. So initially, it is the type 1 fiber which will be there. So shift is there, and there will be collagen deposition which will be aberrant in the extracellular matrix of the OA muscles, with decreased cell density, as well as if there is anything which is extracellular deposition is there, that will lead to the loss of the muscle strength. So whenever someone is having a chronic joint pain, there will be a compensatory movement pattern. Most common compensatory movement pattern is there will be more weight bearing in the normal side on the or the contralateral side, and you will find most of the patients telling you that I am having pain only on the one knee, and why are you getting X-ray done for the other knee? And on X-ray you will find that both knees are showing degenerative changes. and it will be difficult for you to explain at some point of time. The patient will be saying, "You have wasted my money on getting an X-ray done of the other knee." No, always you have to compare, and it is the compensatory mechanism that is working. Not compensatory mechanism is working only on the contralateral knee; it is working on the same knee or the same joint as well, or the muscles along those joints, which leads to disuse related muscle atrophy. Or there you will find that the change in the curvature of the tibia will be there, and also neuromuscular coordination will be there. You will find many patients with OA knee going predominantly walking with a toe or a heel as per their compensation, and which they develop. Another case it can be if there is some weakness of the intrinsic muscles, there will be loss of power. Because of the loss of power, joint instability will be there, and because of the joint instability, there will be abnormal loading pattern. In the moment knee joint loading pattern or any joint loading pattern becomes abnormal, degenerative sorry, degenerative changes will start, and it will get exaggerated, and then leading to mechanical pain, and the mechanical stress will be there. So it is just like a dichotomous framework. In earlier stage, what you can do is go for the anti-inflammatory therapies or neuromuscular training or resistance exercises, which can be progressive, as well as nutritional support in the initial stage of the ONE or the sarcopenia. As it gets worsen or progressive phase, or the mild to moderate early stage, severe stage, then you have to just start planning other way around. It is the you have to preserve the mobility of the joint, because the more mobility will be there, more worsening will be there, more degenerative changes will be there. Why more degenerative changes? Because in the progressive disease, this abnormal loading pattern will be there, which will lead to worsening. Then comes the pain relief, anti-inflammatory, pain relief, and then work for the quality of life, for which progressive phase, the quality of life improvement, the role of therapy gets limited. Then role of orthosis becomes important, kneecap, knee support, whatever. And then the what type of kneecap or knee support to be given, it all depends on the x-ray clinical finding and your clinical acumen. And mobility preservation has to be there, in which you have to advise for the lifestyle modification, architectural modification in the patients. So it is just like a dichotomous framework. In initial stage, muscular training, resistance exercises. In later stages, limited the progressive resistance exercises will be there. Nutritional support, definitely calcium and all has a good role. Vitamin D supplements may be needed. Osteoporosis has to be worked on, and anti-inflammatory therapies always has a role, but it should not be for lifelong. It has to be limited, because many patients with ONE will turn up to your clinic with poor creatinine. Whenever you are prescribing anti-inflammatory, make sure to go look out for the kidney function, because it is all most of the NSAIDs are available over the counter, and people are misusing it. And osteoarthritis is one of the common diseases where there is misuse of NSAIDs, which may become detrimental at some point of time. So take OPD message. ONE and sarcopenia are comorbidities of synovial gland. They are with each other, or you can call it sarcopenic osteoarthritis, because sarcopenia leads to osteoarthritis, or osteoarthritis leads to sarcopenia. So whenever you are managing a patient with osteoarthritis, you have to work on the muscles, you have to work on the cartilage, and we have to think about it. Most of the medicines that are available or that is being researched is on the cartilage, how cartilage leads to osteoarthritis, cartilage destruction leads to osteoarthritis. Yes, but sarcopenia has to be managed in totality or for the holistic approach. So that's all. If there is any questions are welcome. And all those who wish to join the rehab adda can join through the link that I have shared, or through your friends, whoever you wish to join in. So anything to be asked? because this month we will be covering all osteoarthritis complications and everything. 1 month for the osteoarthritis. At any point, please feel free to share or anything new you all wants to ask. Always be there. Okay. Thank you for joining. So fast, there is one reference which I will share. There are few references. I will share one of the good narrative review is there for all of you to read and understand and decide what to do, what not to do, and how to approach. Okay, thank you. Have a tea and enjoy. So that's all we have. Okay. One question: how helpful is muscle strengthening be of help in elderly with grade 4 ONE? I am not sure. Evidences are poor. Level of scientific evidences for muscle strengthening in grade 4 ONE is poor. And what I personally think, it may not help much because at one point you are going to provide an orthosis for this grade 4 ONE, and other side you are going for a strengthening. No, not at all, because strengthening will not be of much help. In grade 4 ONE, most only we are confined to for the pain relief, and we work on the functionality. So this there is already a misalignment of the joint in grade 4, not much of strength, and there is no such scientific evidence available that one should go for the muscle strengthening in these patients. It has to be early. It has to be as early as possible. Especially that's why preventive measure for ONE is to work on sedentary lifestyle and make people aware of it. There are some physical modalities which people are trying, but it has a limited role. Temporary relief will be there, not for a much longer duration. So better, best thing that I prescribe patients to go for the ice pack. 10 minutes, that is more than enough. Nothing much to be done. Okay, we will end then. No more questions. Okay, thank you. Thank you all. Next week again we will discuss some topic related to osteoarthritis. Osteoarthritis is itself a big topic to take on.
Deepika, you can stop recording.
Yes.